Good afternoon, everyone, and Assalamu alaikum. I'm Dr. Tanya. So I will be moderating today's session and welcome to the surgical research seminar. Today, our topic is on ROC curve and true positive and false positive positive things, and then negative predictive value, positive predictive value. And often we have, like, as a clinician, you always have, like, any test need to do the sensitivity specificity test and need to know about that. And that's why I think today's topic is very important. So today we have a speaker among us is Dr. Mohammad Fairuz Shah. He was our ex-clinical surgical master student. He did his clinical masters from 2017 to 2021. Currently, he is attached with as a medical lecturer in UITM. And at present, he is actually doing fellowship under urology as a trainer in UM. I think most of you already know him. So without further ado, maybe Dr. Fairuz, the floor is yours.
All right, thank you, Dr. Tanya, for the kind introduction. So, Assalamualaikum and very good afternoon to everyone. Hopefully, everyone can hear me loud and clear. So, first of all, I would like to thank the surgical research team for giving me an opportunity to actually talk about statistic for surgeon in terms of intermediate for ROC. We are talking about ROC, negative predictive value, positive predictive value. So, for those who doesn't know me, I'm Shah. Can call me Shah. I used to be the master surgery candidate here 2017 until 2021, finished my master and joined back UM as a fellow in urology. Right, so let's move on, not waste time, that we go straight to this is my outline of the presentation. We are going to talk about sensitivity, specificity, then a bit about ROC, residual operating curve, and we will discuss a bit about the area under curve or AUC, simply as known as AUC. Then I will share my experience, how this statistical analysis, I use it during my master's time, during my master of surgery. And I'll give you some example of how to apply for the use of this ROC and AUC for statistical application. And I believe that some of the participants, or should I say that most of the participants here is actually a master student candidate in terms of general surgery, pediatrics, and neurosurgery. So I will share a bit of my experience and tips and tricks and how do I do research during my master time. All right, so this is our learning objective. We would like to actually understand simple biological terminology related to ROC, curve, and then after that to apply the medical knowledge related to, I should just simplify a ROC curve in medical practice. So I should have actually acknowledged Prof. Gauri because some of this slide here is actually given by her. Just adjust a bit so that much easier for us to understand in terms of all this terminology and also the application. Okay, so basically this is what we're going to talk about today. Just for the record that I'm not expert in statistics, but I will just share with you what do I understand about this ROC and also area under the curve, and how are we going to apply this statistical analysis in our daily clinical work, right? So we are going to talk about basically sensitivity, what is sensitivity, specificity, and we will look into a bit about the ROC and also the area under the curve. So basically, this is a main priority, main topic for today. So let's just move on to this 4 columns table. This is like famous for if you want to talk about the sensitivity and specificity. I understand sometimes the terminology is a bit difficult for us to understand the sensitivity, the specificity, and then in terms of the positive predictive value, negative predictive value, as much as because some of us are not really good in research, not to say that we have a major knowledge or in-depth knowledge about all this statistical analysis. So make it simple. I try to explain in brief so that everyone can understand what it means by all this terminology. Okay, so let's say that we have these 4 boxes here, and given on top is a disease. And of course, always the disease is always like positive or negative, and put on the left side is actually a test. Test means that any risk prediction model or anything that you created to actually helping you to diagnose whether somebody has the disease or not, and it's always divided into a positive or negative. A binary is always like 0 or 1. Okay, so if let's say that we are given an example, looking at the first column, disease, let's take it as cancer or non-cancer. You have a cancer, positive. You don't have a cancer, is negative. The test is positive if you have a cancer. Negative, you doesn't have a cancer. So I mean, if you do some tests and that test show you is a positive, by right, you're supposed to have that cancer. Okay, so basically, if you look from the first box itself, that if let's say the test showing the positive result, and when in real life you do have this disease or the cancer, we are giving example, so mean that is a true positive, as simple as that. Okay, whether it's, how do I interpret this? Much easier, you just look at the whether it's a positive or negative. Is it a positive? And if the words before that means true, means that the test is correct. You are tested positive and in real life you do have the disease. That is called true positive. This is good because it tends to identify those who are having the disease by doing the test. What happened if let's say the test, let me just show here, okay. What happened if let's say that the test showing positive result, you do some kind of test and the test showing is positive, but in the real life, you doesn't have the disease, you doesn't have the cancer. So it is actually called as false positive. The test giving you a positive result, but in the real life, you doesn't have the disease. So that is called a false positive test, right? Okay, so what happens if let's say the test is negative? You do a test, then suddenly the test giving you the result is negative, but in the real life, you do have a disease, you do have the cancer. So that means it is false negative. The test saying that you have no cancer, but in the real life, you do have that cancer. So that is called false negative. This is the worrisome because the patient might miss the treatment. The patient might miss further investigation to confirm or rule out the diagnosis. So this is something that you need to pay attention to. And last but not least, if you do the test and the test saying the negative result, and in the real life, you doesn't have the disease, that is called true negative, right? Means that in the real life, you are tested negative, and also at the same time, you doesn't have the disease, it's called true negative. So you see that the green color one is good because that is a good test. The test giving you the same result from the test and in the real life. If you test positive, you do have the cancer. If you test negative, you doesn't have the cancer. But if you test positive, but in real life, you doesn't have the cancer, it's false positive test. If you tested negative, but in the real life, you have a cancer, that is called false negative test. So I have simplified here, if you can still remember the diagram before. So the green color means it's good, it's a good test. Means that the tests have high accuracy. You true positive means you tested positive and you do have the disease. That is called true positive. True negative, you tested negative, but unfortunately, but at the same time, in real life, you don't have the disease. That means a good test. It can actually rule out whether you have the disease or not. The problem is the last two things. The last two sentences here is one that false positive, you are tested positive, but in the real life, it doesn't have the disease. That is called false positive. And false negative, you're tested negative, but in real life, you do have the disease. Okay. So how do you interpret it? Actually, by looking at the test itself first. If the test means positive, by right, you're supposed to have the disease. But if the words before that show is mentioned as false, means that you don't have the disease. As simple as that. If the test is negative, the test is negative, but the words before that is false, so means that even though you are tested negative, you still have the risk to develop the disease. Okay, that is meant by false negative test. Okay, so let's, by remembering that the four diagram, the four column just now. So let's discuss more about the sensitivity and specificity. So what it means by sensitivity and specificity. All these are a bit lengthy words. By simplifying for you to understand, sensitivity means how good the test is can actually, if let's say is given the result of positive, that means you do have the disease. The specificity means how good if let's say that you are tested negative, means you doesn't have the disease. All right. So if you're looking from here, if you can still remember, let me just show you with this pointer much easier. So if The top column mentioned here is that positive disease. This is negative disease. This is positive test. This is negative test, right? Sensitivity means how good is actually the test can actually pick up that among the population that when you're tested positive, you do have the disease. So how do you calculate that? True positive means you test positive, you do have the disease, divided by the total population of here, those who are tested positive. Okay, so the one who tested positive is you add these two columns here, the true positive and the false negative. So you got a total of sensitivity patient, as a total patient of true positive. So this is how you do for sensitivity. On the same hand, if you're looking for the specificity, means you're looking at this column, a patient who actually tested negative and they do not have the disease. In real life, they don't have the disease. So it means that the specificity means trying to find out how good your test is to find and to rule out that you doesn't have the disease, means you are healthy. Right. So let's see from here. This is all, as I mentioned again just now, the sensitivity means is trying to actually identify a patient who actually have the disease, who was tested positive and in real life do have the disease. Okay, so again, true positive means that the patient who actually tested positive and they do have the disease in real life, and the false negative and total combination or total additions of the total positive patient means they are tested positive, and even though they are tested negative, but they do have the disease. So you divide these two combination, you got the sensitivity. On the other hand, specificity, we are trying to find how good the test is able to test those who doesn't have the disease. In other words, they are true healthy patient. They are negative for the test and they are negative for the disease. They don't have the disease. So again, you do true negative divided by the total combination of those who doesn't have the disease, who are healthy patient. That include the true negative plus those who are actually tested positive by the test, but in the real life, they doesn't have the disease. So that is called specificity. Okay, so for this is just what we have discussed just now. This is the definitions of the what it means by the sensitivity and the specificity. Again, the patient who those are tested positive in this column belong to this column. This is called the patient. They are tested positive, and they are the one who with the disease. The healthy patient is those which belong to this column. They doesn't have the disease. They are healthy population. True positive is the number of cases that are correctly identified as patient. Means again, we are repeating ourselves. This are tested positive and they do have a disease that called true positive. The tests are telling you that accurately this patient have the disease or have the cancer. Sometimes the problem is the test tend to mess up. The diagnostic tool tend to mess up. So what happened is you are tested positive, but in real life, it doesn't have the disease. So that is called the number of patients that incorrectly identify as positive. They don't have the disease, but when they do some kind of test or some prediction model, the result will tell them as a positive. So that is called false positive belongs to this group. Okay, self-explanatory for this negative test, that for those who are actually having the disease called false negative, and those who doesn't have the disease and they are tested negative, that is called true negative. So we have talked about sensitivity, we have talked about specificity. Basically, sensitivity just to see how good the test is, can actually identify those who are actually having a true positive, tested positive, and those who doesn't have the disease and tested as a negative is called as specificity. Okay, so now there's another two new terms that initially introduced here. It is called as PPV or NPV. What it means by PPV is basically means that it is actually want to test how good is your diagnostic model, how good is the thing that sometimes you have created a diagnostic test or something that to actually identify if let's say you are tested positive, how many percent that will be a true positive, mean how many percent that you will do have the disease. Okay, so in this term, the PPV are looking at this, are looking at this row here. Okay, you're looking that if let's say somebody is tested positive, okay, how many percentage or how many percent that a patient can actually turn out to have that disease, turn out to be have that cancer. So it's called positive predictive value. Same things happen for negative predictive value. So it means that negative predictive value, if you are tested negative, how many percent that test will tell you, okay, you don't have the disease. You are correctly belongs to those who are actually belongs to a healthy population. So in a simple word, true positive mean if let's say that you're tested something with a positive result, how many percent will you be in the population tested as those with the disease, right? Let's move and let's look further about the. Okay, it's okay. We will do the activities later, and we will discuss about it later in the few example. So in understanding about all these four terminology, we'll move on to something is more interesting and more in depth in terms of diagnostics tool or prediction model. This is called ROC curve, receiving operating curve. Okay, so what is this curve will tell you as a simple part? I will show you and I'll give you example later. This curve is actually marked by a true positive rate, mean how good the test can actually predict, or how good a prediction model can tell you if you're tested positive, you have the disease. Against x-axis is a false positive rate, means simply as 1 divided by the specificity. Okay, so if you look at this graph here or this curve here, if the test is like this line is the red color line, that means the test is actually just about as a random classifier. The test cannot tell you whether this you are having the disease or you doesn't have the disease. Something is just like a basic test. Looking at the curve here, if the test is pointing or skew, if the curve is skew more towards the left side, means the test will tell you, okay, if you are tested positive, you do have a disease. If you're tested negative, for sure you can be rest assured that you don't have a disease. That is called a perfect classifier that have the AUC or area under the curve of 1. Okay, you just remember that if the test you do a AUC and you do a ROC and your line or your graph is pointing towards more of this direction, pointing towards above, that means it's a good test. Okay, that means your test, whatever you have created, your prediction model is good because it can help you to identify or diagnose a disease in the population. Okay, you have to understand that for you to create a diagnostic model, you need to balance between sensitivity and specificity. We have talked about sensitivity means able to pick up the positive, able to actually rule out those who have the disease, or the negativity means can actually identify those without the disease, right? Okay, so what it tells you is that if let's say you tabulate the curve and the curve is pointing towards more on the left side, more up to the value of 1, means that is actually a good diagnostic model. Above 0.5 is considered good test. If less than 0.5 means whatever your diagnostic scoring system is not to say is good, but it cannot tell you whether the patient have a disease or not. So it means it's just a random classifier. So remember that AUC stands for area under the curve, means that when you do the ROC, you calculate the area under the curve of this graph, that the more the value above 0.5, and if we can reach up to the point of value of 1, that means the better the diagnostic prediction model. Okay, in this case, if you can see the blue line here is a better prediction model comparison between the green and also the orange, because the what do we call, the graph is curved or is pointing more towards level of 1. Okay, this is how we discuss. If let's say that you got something you calculate, you put inside the Stata or any SPSS, and the value was mentioned that your diagnostic prediction model or your diagnostic scoring system is about 0.5, that means whatever that you have created is not really good, it's not really strong enough to help you to diagnose a disease in the population. Okay, so let's move on to some bit of about revision activities. And we're just looking at this. Let me just share back again. We are looking at this slide here. Again, just trying to memorize back again. On top is the disease. On the left-hand side is your test. is this one is true, means it's positive and negative, and this is positive test and this is negative test. So let's see how do we actually calculate, or how do we actually identify which one is sensitivity, which one is the specificity, positive predictive value or negative predictive value. Positive predictive value again is telling you if you're tested positive, how many percent that you will most likely probability or likelihood to have the disease in the population. Negative predictive value means if you're tested negative, how many percent that you will not have the disease in the population, right? So let's move on. So this is the how that we do. It's actually the sensitivity, again, the true positive, it is here, A divided by the total number of positive population. So A divided by A plus C, this is belong to this part. Okay, and if let's say that you're measuring about the specificity, specificity against a true negative, D divided by the total number of those of negative population, or those who are actually a healthy population doesn't have the disease. The sensitivity is those true positive who have the disease tested positive. The specificity means is those who are tested negative and really doesn't have the disease, right? Positive predictive value, if you're tested positive, how many percentage that you will likelihood or most likely will have the disease? And the negative means negative predictive value means that we are tested negative, how many percent or how many chances or likelihood that you don't have the disease in the real life, right? This is how you simplify of this table. Okay, so let's move on. So let's see a bit of example. So a given of two examples here, A and B, and this is the one that looking about the sensitivity and specificity with a prevalence of 50% and prevalence of 1%. What it means by prevalence means prevalence is the patient or total numbers of those with the disease in the total population. So if you're looking from here on the table number one, table A, those with disease means belong to this category, belongs to this part, the positive one. Those who actually have the disease, have the cancer, they are belongs to this group. So 100 divide by total number of population is 200, you got the prevalence of 50%. Means that whatever the disease is, whatever the cancer is, quite prevalence in the population. But if you have, on the other hand, positive for about 100, and the total population is about 10,000, so the disease is just prevalent about 1%. Again, this all based on your sample size calculation, right? So let's try to calculate and let's try to see how do we find out the sensitivity and specificity for these two examples. Okay, we have measured about the prevalence just now. We'll talk about the prevalence, the total number of patients who are tested positive divided among the total population. And then after that, let's see about the sensitivity. Again, we're talking about those who are tested positive, they have a disease and they are tested with positive result. Among those who are tested positive, among those who do have a disease. So you calculate sensitivity is 95 divided by total total with the disease or total with a positive condition. You got this about 95%. Specificity means they are tested negative and they in real life doesn't have the disease. So 99 divided by 100, you got 99%. So if you look at this sensitivity and specificity, mean this test, whatever the prediction model test, is quite good because you got about 90% sensitivity and 90 above the 90% of sensitivity and specificity. Then we look furthermore about the likelihood of you, if you tested positive and you got the disease, is called PPV and NPV. With PPV is this part, those are tested positive divided by the total positive test result. So you got this 95 divided by 96, total of here, and you got a positive predictive value of 99%. So what it means that if you are tested positive for that test, 99% likelihood that you do have the disease, right? That is what it means by the positive predictive value. On the other hand, negative predictive value, what it means by how do you calculate is you divided this 99% numbers of the total of true negative, they are tested negative and they don't have the disease, among or divided by the total number of those who are actually tested negative. Because we understand diagnostic model or prediction model, sometimes they can mess up. They will tell you something is very funny about the result. That's why you wanted to actually measure how this thing likelihood to give you a better result. So this is called negative predictive value that you divided, the result is about 92, 95%. So that means that if you're tested negative, you can be rest assured that likelihood you don't have the disease in the real life, because the negative predictive value is quite high, if above or more than 90%. Okay, on the same example was given on B, we are talking about prevalence, sensitivity, and specificity, more or less about the same. But if you're looking at the positive predictive value, the value is only about 49%. So that means that if let's say that you're tested positive, you can be 50-50. 50% that you got, maybe you got the disease, or maybe 50% you doesn't have the disease, because the positive predictive value is only about reaching about only about 50%. Okay, so that is how you interpret the result of this diagnostic, result of this statistical analysis. Okay, so let's move on. In summary, so what we have talked about is actually this how to identify who are true positive, who are actually true negative. True positive again means they are tested positive for the diagnostic test and they do have the disease in real life. And true negative, they are tested negative and they don't have the disease in the real life. These are good because these are the accuracy tests. They're giving you a high accuracy diagnostic model. Means they are tested and you can rely on their result to actually identify whether the patient have the disease or not in the real life. The problem is this red color part, actually, because they are giving you something else rather than the true result. Those who are actually tested positive, but in real life they doesn't have the disease, the positive result that you get from the test is false. So that is called false positive. On the other hand, the same thing, when they tested negative, but in real life they do have the disease, is called false negative. These are the group of the patient that you need to pay attention to, because these are the patient or the group or the population that tend to miss further investigation or further tests to confirm the diagnosis. We'll talk about AUC and ROC, just as for you to remember, to simplify that if you got an AUC more than 0.5, if you see some of the paper that they mention area under the curve, and the value is more than 0.5, that means it's quite a good. The higher AUC value, the more precise, or the more good, the more or the better diagnostic scoring system is there, or the better prediction model is there. Okay, remember that if the graph is skewing towards above, that means it's a good or better prediction model. Okay, so I think we have talked about the positive and the negative and predictive value, and we talk about the sensitivity and specificity. On the next of my talks, actually, I would like to actually share with you how do I apply this statistical analysis in my thesis during my Master of Surgery training last time. Okay, so this is what I did before. If those of you coming from the general surgery or pediatric surgery, this is a real paper that was produced from our institution in 1993. At that time was called University Hospital or UH. That they have found that 102 patients who were actually diagnosed as acute appendicitis, but they went in for surgery, turned out to be a non-inflamed appendicitis. So given a diagnostic error, it's about 19.3%. So you can see from here, these are the examples of why patient diagnosed as acute appendicitis went in for appendectomy, turned out to be something else. So in addressing about this problem and this issue, we created something called a Malaya score. This was a few steps for us to create this Malaya score. The Malaya score was created based on logistic regression analysis and multiple regression analysis. So we come up with these few criteria that actually trying to increase the accuracy of diagnosing of acute appendicitis. We know that acute appendicitis is a clinical diagnosis, but whether we can actually help on trying to further classify or trying to further rule out other disease or other condition that can actually mimic acute appendicitis. So that's why we created with this scoring system. You can see from here, we add few things that are not available or not there in the common Alvarado score. So we put something is like male patient, we given an extra of 2 score. And a symptom is, let's say the abdominal pain is more than 48 hours, given additional 1 score. No URTI symptom. We understand that sometimes those, especially the pediatric patient, they can have this URTI, mimic mesenteric adenitis, came with acute appendicitis, and we have ruled out no UTI symptom. And in terms of signs, we actually amplify that the clinician is to actually check whether they got any costal vertebral angle tenderness, and to check the throat whether they got any sign or inflamed throat or inflames like suggesting of URTI, given a score of additional of 1. And then after that, we wanted to actually not only see the white blood cell, we wanted the clinician or the surgeon to actually rule out and to see the urine analysis whether they got any suggestive of UTI that may tell you that this patient maybe probably got UTI instead of acute appendicitis. So we given a score about 15, and we add about our score got about 12 criteria. So this is how we do. This is how I tabulate the result and tabulate the graph into this so-called of ROC and AUC. So you can see from here, the ROC score of 12 have the highest Jordan index. Jordan index means you tabulate the plot inside against few what do we call, a few of the cutoff point, and then you see which one that's given you the highest sensitivity and specificity. Okay, you need to understand, for a good diagnostic test, a good prediction model, you need to have something that is having high sensitivity and high specificity. But in order for you to get the high sensitivity, you tend to compromise on the specificity. Means you can pick up the whole case, but you tend to lose those who can actually rule out those who doesn't have the disease. But on the other hand, if you go for specificity and you're trying to compromise in terms of sensitivity, so the Jordan index is helping you to find which are the cutoff point that giving you the acceptable sensitivity and the specificity. So, and we measure our AUC, and the AUC of this test, Malaya score was given about 0.703. So in terms of observation, about 200 plus. So we come up with the sensitivity and specificity of Malaya score at the score of 12. It can actually give you the sensitivity about 61% and the specificity of about 70%. So we do compare this test with the conventional Alvarado score, and our test is better than Alvarado score. So okay, so that is sharing of experience. How do I apply of this statistical analysis in my thesis and during my Master of Surgery training previously? Okay, so I believe that some of, not to say some, but most of the participants here is actually master candidate, regardless whether you're doing in the pediatric surgery or general surgery or neurosurgery. So I'm going to share in my last part of the talk. Actually, I'm going to share to you a bit about how do I do my research and how do I do my thesis during the last 4 years when I was in general surgery program. So I understand that doing a research and at the same time doing a training for clinical is a bit taxing, and I believe that sometimes a bit difficult, and especially for those who have not to say a good background of research or good backgrounds of in terms of statistical analysis knowledge and so on, a bit difficult for us to actually proceed by doing a thesis. So I'm going to share you few tips that I do, and I hope this will benefit you in terms of doing your thesis or doing your research during your master program. So we understand that we are quite busy. Sometimes you have no time to collect a data, and especially some of us have no knowledge in research and statistics. And most of the time, sometimes, not to say most of the time, but sometimes we are not interested in doing a research. So what I'm suggesting is actually to don't delay your research until the last minute, because to collect a data itself, in this case, in an example of my study, I have to collect about 300 patients' data. So then it's a bit taxing if you wanted to actually put it in the last minute. And at that period of time, we are busy with all this clinician, and some of us are busy with clinical work, and then sometimes we have to go outside, external rotation and so on. So what I did is actually every day after my thesis has proven with all this ethic and so on, what I do is every day I make it at least compulsory to collect one data for each patient. So if let's say that you're collecting the data for one patient, in my case I need about 300, you need at least about 1 year to collect all the data for all the sample. Because collecting the data, of course, we understand it's a prospective study that you need to check the patient detail, you need to check the patient laboratory investigation and so on. Sometimes it's a bit taxing. So I'm suggesting if in a day, if you cannot do 10 minutes, at least 5 minutes, just open up your research, open up your thesis, add on, just edit something so that it becomes like continuous effort rather than you're putting everything at the last minute. The next one is actually This is quite interesting. I'm not sure whether any of you know this person. This is Prof. Kulantaren. So what I did is actually when I came up with the idea to have a diagnostic scoring system for Malaya Score, I found one advertisement about this a course that was conducted by Prof. Kulantaren. Prof. Kulantaren basically is our prof in Merdu in UM. He is quite expert in all these theses and quite expert in terms of creating diagnostic score and so on. So I approached Prof. Kulantaran. I expressed my idea and expressed my thinking to do this as my thesis program. He is quite happy to help and is very supportive. As you can see from here, I'm showing that this is my chat with Prof. Kulantaran, my email that we are sending to my email that I'm sending to him about my thesis, my data, and so on. So what I'm trying to say to you is that sometimes you have idea, but you want your idea to become solidified. You need help to improve, and you need sometimes that you wanted to get other opinions, other view of your idea or your thesis problem or thesis issue. It's always good to ask somebody who are expert. All you need to do is just asking people around. So it's up to you whether sometimes that their idea or their opinion may be not relevant to you, but sometimes you might think that something is benefit and something that you don't think about it, and at the end of the day is giving you some benefit or giving you some idea for your thesis. Example I'm going to share to you, a second one is this. As I mentioned to you just now, we have created Malaya score, and we found that the Malaya score, if you see from here, the last paragraph here, the negative predictive value is only about 3%. So means that if you are tested negative with the Malaya score, but at the end of the day, you are tested positive for the acute appendicitis. When I create this scoring system, when I do for my thesis, I put it there as a study protocol that I diagnose or I label a patient to get the acute appendicitis or to label a patient as acute appendicitis patient based on the interpretation of the HPE. So means that the patient went for surgery, and then after that I look at intra-op. Then after that, my positive finding means the patient labeled as a positive with that disease is based on the interpretation of the HPE from the biopsy of the acute appendix. So when we found that, I was looking at trouble. Why is my negative predictive value was quite low? It's only about 33%. And means that when the patient was tested negative, they still have the positive HPE. Mean they still have the disease of acute appendicitis. So I was trying to figure out what I can do, whether I can change the scoring system or something that I should have done to make it more or to increase the specificity and so on. Then I make appointment with the Prof. April. For those who know that Prof. April is very good in research and so on. And Prof. April, I remember that the day that I met, I made an appointment to actually discuss with her. I presented my thesis and I presented my issue and everything. And Prof. April giving me one that things that I was never think about it before, and the thing that I was never realized that yes, it can influence my thesis or my result of my study. So she mentioned that maybe you would like to look back again the interpretations of the HPE result, whether it's a true appendicitis or something else. So that has triggered my mind to actually look back again and to further study about this HPE result of acute appendicitis. So that means that this is actually was published in a journal that mentioned that for you to diagnose or to confirm the HPE is because of acute appendicitis, you need to fulfill this criteria. Means a neutrophilic infiltration of the mucosa, submucosa, and muscularis propria, and they have transmural inflammation, means across the whole wall of the acute appendicitis. If it's just a bit of neutrophil within the mucosa, or if you can see from here, if let's see that the first part is here mentioned that small accumulation of neutrophil probably is not significant. If we just neutrophil within the mucosa or mucosa ulceration, maybe the thing is not responsible for the patient's symptom. Maybe the patient does not have acute appendicitis. You need to consider something else, example of infective enteritis and so on. Or if let's say that the mucosa is just above, the neutrophil is just above the submucosa, again, it may not be responsible for the patient's symptom. So that has triggered my mind because when I did a study and when I collect the data, I only interested about the interpretations of the HPE result. I didn't look into the microscopic part of detail about how they actually look up under the microscope. So as I'm showing to you, this is an example of true positive HPE. And this is the thing that was documented as a true acute appendicitis. You see the mucosal ulceration with luminal acidate. and there is an infiltration of neutrophil transmurally. So it fulfills the criteria of the diagnosing of acute appendicitis based on the HPE. Then based on my study, what I look for is only as this part. I'm interested about when I first collect data, I was only interested about this part, the interpretation of the HPE, whether acute appendicitis or so on. When I further look into the microscopic part, and I found that it's actually, if you can see from here, these are the examples that are labeled as acute appendicitis. But again, if you see at the microscopic part, it's only mentioned very occasional neutrophil seen. It means that it doesn't fulfill the criteria to diagnose acute appendicitis based on the HPE result. So these are the few things when I realized, when I presented this case to Prof. April, then Prof. April was giving me this idea and also this issue, then only I realized that some of the patient that was tested negative with acute Malaya score and turned out to be a positive HPE in real life, maybe not a true HPE result because it doesn't fulfill all these criteria. We see from here very occasional mucous neutrophil seen, and the appendix very occasional focal neutrophil within the mucosa, and they mentioned that suggestive of early acute appendicitis, and occasional focal neutrophil seen, again suggestive of early acute appendicitis and mild appendicitis. So that's what I'm trying to say to you is that sometimes there are things that is not triggering you, something that you don't come across to, something that you don't think about, you have no idea about this thing can influence your study. But the only things that you realize when you talk to somebody else, when you go and ask other opinion, especially for those who are more experienced, they will tend to give their input, and this input at the end of the day is valuable and is giving you some benefit to your study. So that's why I'm trying to say to you. And the next point is actually in terms of trying to help you with the thesis and so on, is to have a supportive supervisor. I am fortunate enough that when I was given a supervisor, that I was given the Prof. Kalai and Dr. Haris. So the good thing is when I first approached Prof. Kalai, I mentioned that I have this idea. I have this idea about my thesis. I would like to proceed and so on. And Prof. Kalai expression was at that time, go ahead, try and present your first thesis defense and see a first what do we call assessment for your thesis. And if let's say it's successful and have no objection, proceed with your project. So that's what I did. I create my own thesis. I create my own research problem, research issue, research diagnose, research topic, and so on. I approached Prof. Kalai, and Prof. Kalai said, "Okay, go ahead and proceed." And this is my response from Dr. Haris. Is also one of my supervisors that mentioned after I finished my thesis defend, and unfortunately I had to redefend back again. So he mentioned that good. So what the thing is, what I'm trying to say to you is sometimes your supervisor do have a thesis research topic that they also planned for you. So if let's say that you don't have idea or you don't have any topic, it's always good to talk to your supervisor. Don't make it as a habit that to always approach your supervisor at the last minute. Don't make a habit that trying to actually when you have a problems only that trying to actually contact or meet your supervisor. Do have a habit that regular meeting with supervisor and update the research project so that they can actually help you along the way. And last but not least, what I'm trying to say to you is that go further with your research. This is after I finished my Master of Surgery in 2021, I submit my thesis to this surgical meeting that was done it was done virtually because at that period of time was actually having a COVID and so on. So I presented an oral during at that time, and it was a good meeting and got a good input from somebody else from Singapore. They mentioned about, this is actually quite a good what do we call diagnostic scoring system that can help to maybe to rule out whether they got other possibilities that can mimic acute appendicitis. Again, when I think in next 2022, I submit again my thesis and my idea of research to this American College of Surgeons meeting, ACS, and fortunate enough that was accepted to actually publish. And that time was also again done virtually because of the COVID and so on. So again, that your thesis is actually recognized outside. So if we have a chances, if you do a thesis, if you do your project, your research very well, that you have a chances to further and to go and collaborate with other people. So and you have a chance to actually present your thesis or your research into that one of the prestige surgical meeting. And this is my colleague. this is quite new. It's actually quite fresh that one of my colleagues, Jolene, who's currently is consultant GS in one of private hospital. She did is actually this is actually her research topic, that her thesis topic that was done during his master program. So you see that if you've done well, you've done proper manuscript writing, you've done proper research, the world actually will recognize your research by allowing you to publish in one of the prestige journal. This was published recently in this month at the World Journal of Surgery. Okay, so at the end of the day, I hope that this session that will actually help you a bit about all this. Of course, we wanted to learn about the statistical analysis and so on, but I hope they will give you eye opener, because at the end of the day, this is what you are aiming for. You manage to complete your thesis within the period of time, manage to defend your thesis, manage to actually complete your thesis within that allocation time, and publish it, right? And if let's say that you're given a chance, do go further with your research, publish it or present it into an international conference and so on. And at the end of the day, because in order for you to proceed or to sit for your exam, you need to pass your thesis. And I hope that one day that you're able to finish your thesis and pass your exam well, then after that, be graduate, become a surgeon. With that, thank you for your attention and thank you for attending this session. I pass back this to Dr. Tanya. Thank you.
Thank you, Dr. Faiz. It was really very good session, and especially sharing your experience and how you change your research. It was really good. Like people shouldn't stuck somewhere, and then they can improve actually themselves, right? And also thank you for encouraging them. So now we can have some QA session first. Anyone has any question? Please, either you can raise your hand or you can ask straight away to Dr.
Right. So
Faiz.
I have a question. Good. Now is that Prof. Gauri is already joined us. So anything that need for clarification, Prof. Gauri will help us to actually answer the question. And just to add for the record that actually you have, not to say that we are alone in doing a research. We got a good team here, led by Prof. Gauri, Dr. Tanya, and so on. Their surgical research team are very supportive. I still remember got one time I make appointment with Prof. Gauri in Cube, I think, if I can remember correctly. I show this thesis program, thesis research, and so on. So she was very supportive in helping me to actually go ahead and move on with my research and so on. So it means that what I'm trying to say to you is you're not alone in doing your research. And if you have any problems, talk to somebody else, get other opinions. Those are more experienced. If you're stuck in between, so don't feel sad. Don't feel actually you feel a bit of depressed and so on. There's always a chance to try to help you, chance to try to recover, try to help you to proceed and finish or complete your thesis. All right. I think the good things that we have no questions means everybody understand well. Everybody at least have some part of some bit about the
You
knowledge
know,
of.
ask some questions, not to you particularly, but to the group which is here. How many of them did you ask them? Like, how many of them actually are hoping to use ROC curve or do a similar kind of analysis in their theses, or they are here to just learn about it? Yeah, like how many of them are actually going to do it as a thesis?
Yeah, so any of you that are doing ROC or looking sensitivity or specificity or creating a risk prediction model that trying to rule out any other disease in your thesis, would be great. It would be good if you can share your experience or any difficulty that, and if let's say that's something that we can try to help to, that would be good for us, because we have a Prof. Gauri here also with us now.
No question. They all were understood what was going on. I only was able to join towards the end because we just finished the orientation for the new batch. So that's why I asked Tanya to moderate. If not, I would have joined from the beginning. One pointer which based on what I listened to at the end, you can see that a lot of pre-validations. I think it's given you an example of that is very important how you measure your main outcome and how you validate that outcome. So like you need to actually use the right tool. So yes, you can come up with the score and come up with a cutoff, but you really need to make sure the data which you key in and the data you collect is as as robust as possible, right? I think that was the point which you're bringing across. So thank you for doing that. Yeah.
Yeah, glad to help.
Yes. And I think it's not like every student have to do or anyone need to know ROC because they will do. Because as a doctor, whenever any new biomarker for any diagnostic tool comes, there is some question like how much sensitive is it specific, right? So as a doctor, you have to have some clear concept, right? How much the sensitivity test percentage specificity, so you can understand, okay, you can apply in your real life or not, right?
Yeah, in
Dr.
clinical practice. Yeah.
Yes, clinical practice.
Yeah, so
Dr.
ROC curve is not just for your research projects, but if you see, obviously, COVID is based off the sensitivity and specificity, right? COVID vaccines, COVID testing. Otherwise, urology, I think, is quite famous because of the PSA testing. So yeah, so it is not that something which you only need to know to run your thesis or convert it into a paper, but something which you need to understand when a test results come back to you, like how much of it is actually picking up the disease, and how many of it is negative, is a negative result, whether the test needs to be repeated. All of that needs to be something which you need to be able to critically think. That's the point Tanya is bringing across here. Yeah.
Agreed.
Shai, anything to add in regards to that aspect, maybe like in terms of clinical practice? Yeah.
Yeah, so again, as I mentioned to you just now, when somebody created a diagnostic or prediction model, so there are a few things that you need to look into, like Prof. Karim mentioned. You want to look how sensitive the test is, how specific the test is, how the test can actually give you a good or high negative or predictive value, and you want to see that how good is the test can actually try to relate whether you have or not have the disease in a population. So that is what something that you need to pay attention to. And as if you can see that if you understand the basic about all these terms, this will actually help you to actually identify whether this test that you have created, whether it's good or it's just like something, it's just like random classifier in terms of a disease. Yeah, that is what my take home message from this session.
Thank you, Dr. Biden. Anyone has any question or any comments or anything you want to share? So I assume none of them are doing ROC curve, but I'm happy to see many of them actually join today to learn. At least they will take some information. And especially I really like your experience and how you change, because even if all of them are not doing ROC curve, still they are doing some kind of research, and any research, actually there are sometimes negative finding or biasness inside the research. So actually the way you show how your experience or you approach to many people and then you overcome your problem with the negative sensitivity one, actually shows how sometimes research actually affected by the biasness or other issues surrounding, and then they need to look for it and then they can actually overcome it. That's actually a very good point also. Okay, so I think for today, after this, we have the next session on the 25th June, if I'm not mistaken, on survival analysis. And our next presenter will be Prof. Simi Hung. So thank you once again, Dr. Fairuz, for giving us your fruitful information and sharing with everything us. I think that's all. Thank you. Thank you, everyone.